purchased the OPD because I wanted to have a number of diagnostic devices and wanted to find a way to have it presented in a fairly efficient manner. For me, it provides an autorefraction, a wavefront refraction, a topography that allows me to look at higher order aberrations of the eye, of the cornea, and really provides all that information under one setting. And that's just ideal if you're trying to have a busy cataract refractive practice and provide best patient service in a fairly efficient manner. For me, the OPD is part of our preoperative screening, which is fairly intense for premium IOL patients. The biggest challenge we face today is getting our refractive outcomes where they need to be. We're spoiled. With LASIK technology, we're used to 90 to 95, 97% predictability with our refractive outcomes, which is what patients are interested in. How well can I see without glasses? When we get on the cataract side, we're not where we need to be. So technologies like the OPD, I think, improve our accuracy, improve our surgical planning, so we're doing a better job on the front end. We're still not where we need to be, but I'm convinced that technologies like the OPD are on the right track to getting us there. You know, I'm a pretty high-tech practice. I have a lot of the new state-of-the-art cutting-edge equipment, from femtosecond lasers and excimer lasers and all of that. So I think patients expect us to have really high-end diagnostic devices. Yeah, my staff can be rigid at times. They don't want to have to continually relearn things or learn new things, but the adoption of the OPD was great. I think one of the biggest advances or helps really was the online training that was done in addition to the on-site training, and my staff loves it. They find it easy to use. Patients really find it very easily to tolerate. The lights aren't too bright. It's pretty quick, and the information is really awesome. You know, patients who've had previous refractive surgery, LASIK, PRK or RK, continue to be a big challenge. They've already had a refractive procedure once, so we all know they're motivated to see well without glasses. They've paid once for a procedure, now they have cataracts. They're willing to pay again if technology is available, but they want to have their refractive outcome be optimal. We're not where we need to be with any of the cataract technologies. You know, LASIK is more predictable with a virgin cornea than we are with cataract surgery with virgin corneas, and people that have had previous refractive surgery are less accurate still. I use technologies like the OPD to give me a better understanding of where the astigmatism lies, to give me a more accurate corneal reading for keratometry measurements, which are really important to determine the best fit lens. At the end of the day, that's really what it's all about. I think we're going to continue to move forward with other technologies down the road, but the OPD plays an integral role in determining post-refractive patients prior to cataract surgery. So correcting astigmatism continues to be a growing area for cataract surgeons. In fact, most cataract surgeons, when they want to get into the refractive cataract realm, are moving forward with toric lenses or arcuate or limbo-relaxing incisions. So the first challenge or dilemma is where the axis of astigmatism is. So you need accurate information, keratometry readings, autorefraction, and really corneal topography to determine where that astigmatism lies at the time of surgery. The nice thing about the OPD is it not only gives you all of that information under one platform, but you've got photographic evidence as well of everything pre-op. You can take an image post-op and then follow it over time. If the lens is going to rotate or move, you'll know it, and you can tell exactly and just compare pre to post. And so that's just ideal. And if you need to reposition, you'll have your early information as well as your early post-op visits again to use as a guide. You know, there is a thing called night myopia, where patients can have their refraction change, in fact become more nearsighted in dimmer illumination, and it's probably due to changing in the size of the pupil, especially in younger myopes. The nice thing about the OPD is it'll give you a refraction at different pupil sizes, and you can make adjustments for that. And we've had several patients, many patients, especially younger myopes, where we'll give them a thin prescription for night driving. Post-LASIK patients whose prescription is spot on, but they may have some issues with night driving, we can detect with the OPD and give them a very accurate reading and prescription that solves the issue. It's not glare and halo, and if you measure them in your office conventionally with Snellen acuity, you'll find that it's not a refractive error, and you might inappropriately say this is somehow due to glare and halos from the refractive surgery itself, when in fact it's due to night myopia that's often missed. We found it to be very helpful and really solves a lot of the problems, not only from our end, so we're not questioning the LASIK procedure, but also provides reassurance for patients in terms of exactly what's going on. And it really hasn't been an inconvenience for those folks who do have night myopia to leave a pair of glasses in the car for when they're night driving. Solves their problem too. EMR is the wave of the future. I was on a full-time EMR platform previously when I was at an academic practice. With all of the government stimulus, more and more practices are moving to EMR, and there are many, many platforms out there. It's going to be important that the diagnostic information communicate with, can be exported to, and have readily accessible all that information on EMR platforms. It's clearly the way of the future. So the nice thing about the OPD is you can both determine total refractive power of the eye and higher order aberrations, as well as higher order aberrations of the cornea. So at cataract surgery, you would rather rely on the higher order aberrations of the cornea, since we're removing the lens itself, which is full of aberrations. In selecting a best fit lens, you can use the corneal aberrations, and with aspheric lenses you can then choose which lens is the best fit based on that patient. Whether you want to get them to an asphericity or a higher order aberration, or spherical aberration rather, of 0. Some people want to leave them with a little residual spherical aberration. Regardless, the information is there to use as you please. Multifocal lenses work by splitting light, and splitting of light, while helpful in providing different foci so people can be less dependent on glasses for near and far, the splitting of light does have some compromises associated with it. Needing more light to read, noticing more night vision symptoms, and they can, to a small extent, degrade the quality of the image for distance and near. The vast majority of people do really well with it, but occasionally we get someone who does not. Maybe due to pre-existing higher order aberrations in their cornea, things like coma, trefoil or otherwise, that may interfere with the quality of the image from the multifocal. It may also be some aspect of how well people neuroadapt. At the end of the day, we don't really always know, but I do IOL exchanges. I have exchanged, not commonly, but occasionally, someone who is an unhappy multifocal patient. In fact, to me, that's one of the advantages of presbyopia correcting technologies, and specifically multifocals. We tell patients if you're not tolerating it, it can be reversed. Replace it with a monofocal lens. Patients do very, very well. I have had instances where I've exchanged multifocal lenses for whatever reason, and the issues have been resolved most of the time, not all the time, with a lens exchange. Yeah, I'm a big one on efficiencies. At the end of the day, if we're offering premium services and we want to consider ourselves to be a premium practice, people don't want to sit around and wait 2 hours, 3 hours to get through their visit. They're expecting a premium service, not only to have high-end diagnostic equipment, but to be seen in a timely fashion. We were able to change our waiting time on average from the time that they check in to the time they're brought back from 37 minutes. Now we're down to 7 minutes. And we've been able to take our total office visit time for a surgical cataract consult from 2.5 hours down to 1.5 hours, where they come in, they're seen, all their testing is done, they've seen an educator, they've seen me, they've seen a financial counselor, they're scheduled, post-operative drops are given, they're consented, and they are back out of the office within 1.5 hours. The only way that can happen is through rigorous training and really getting your processes down. Everyone does things exactly the same way at the same time, regardless of patient or technician. And it really helps to have efficient diagnostic equipment. The OPD has been awesome in that regard because it combines so many technologies under one platform, where we can get an AR, we can get K values, we can get a topography, we can get a wavefront, all under one platform in a very short period of time. So I think it's helpful. It's not only been helpful for the flow, which it has been, but it's been awesome with patient satisfaction. When we look at our satisfaction surveys post-op, They were always good with people saying, wow, I can't believe how great I've seen. But now we're talking about how great the process was, how quick the evaluation is, how little they had to wait. It goes a long way. I think it's going to be something that's going to define people when you're talking about quality reporting and quality of outcomes and customer satisfaction, which is going to define offices. Office flow has to play a role.